It's December 2024. Ho, ho, ho. And this is the RheumNow podcast. Hi, I'm Jack Cush, executive editor of RheumNow.com. RheumNow.live is coming up February 8th and 9th. Just, about 8 weeks away or something like that. Actually, less than that. Check out the agenda. It's incredible. I'll talk about it at the end of the program. We've got a number of interesting reports at the end of the year here that I thought that we should be covering. Nail fold capillaroscopy, do you do it? I do. I don't just do it in scleroderma and suspected scleroderma. I like to do it in autoimmune disease in general. And I've always been very impressed by the abnormalities on nail fold capillaroscopy in patients with polymyositis, but especially dermatomyositis. I put up a report this week of 76 DM patients, and when they underwent nail fold video capillaroscopy, which is obviously a lot better than the tools that I use cheap tools, but nonetheless, I think very good tools. They found 74% of patients had abnormal nail fold capillaroscopy, diminished density, abnormal morphology, and the patients with dermatomyositis and abnormal nail fold capillaroscopy were more likely to have more Raynaud's and maybe more likely to develop ILD. I think it's a severity marker, and I think it's worth looking at. And of course, you get the hint when you look at these patients and they have periungual erythema or those desquamative changes of inflammation and periungual distribution. I think it's worth doing. A review of sarcoidosis this week came out showing that rheumatic manifestations of sarcoidosis found in a range of 10 to 40%, includes bone lesions, acute arthritis, chronic arthritis usually involving the ankle and tarsus, axial disease, dactylitis we've talked about before, and sarcoid myopathy. Things to consider when faced with those diagnoses, that sarcoidosis could be in the differential diagnosis. Do a chest x-ray, single best test. ACE levels, not a great test unless they have abnormal lung involvement. Do the chest x-ray. That's actually where you're going to find your clues as to sarcoidosis, and then maybe following through on biopsy. We've talked in the past about the percentage of patients with IBD who may have occult spondyloarthritis, and that ranges from like 8 to really about 15%. This particular study looked at IBD patients who underwent magnetic resonance enterography, MRE, where they're looking at the gut, but in doing the gut with MR, they can also get a good look at the SI and pelvis. So they can find occult sacroiliitis, if you will. So in these 95 patients, they found by observation and clinical disease, only 6.3%, 6 out of 95 developed IBD. So it's a low number if you wait for the clinical manifestations. It's a higher number if you go searching for it with camera studies and, or not camera studies, but by doing x-rays and doing more extensive analyses. But again, that seems about right compared to what's been described before. The interesting thing was that finding sacroiliitis on MR studies did not increase the odds of the patient having spondylitis. Turns out that IBD arthritis in general, which is often peripheral, not axial, but could be axial, was going to be most closely linked to having arthralgia, an 84-fold increase odds, right? But also maybe the more predictive feature was extraintestinal manifestations, things like pyoderma and other things that go along with IBD. So keep that in mind if you're thinking about the possibility of enteropathic-related arthritis or maybe even occult sacroiliitis. Rheumatologists love lupus. I'm not sure it really exists. I've had a few patients with lupus. This is a particular study of 41 patients that were compared to 160 SLE and 709 RA patients. Turns out lupus patients are more likely to be diagnosed at a younger age than RA, but older than lupus. So younger than 60 and older than 20. and that's significant. The majority of these patients probably have more of a lupus onset of symptoms, more so than RA, but it's not that far behind. What distinguishes the lupus patients was they were more likely to have ILD, hypergammaglobulinemia, and lab abnormalities, but seldom ever develop renal or CNS manifestations. Now, if that helps you in your diagnosis of lupus, God bless. I'm not so sure I'm searching for lupus that hard these days, but it does show up, right? And my advice, this is not part of the study, it's a lot like overlap syndrome. It doesn't, you don't treat the label. There's no specific drug. You treat the dominant manifestations. If it's an overlap of myositis and rheumatoid arthritis, you're going to treat the myositis if that's the dominant manifestation. And most likely they'll take care of the RA, right? Same thing for, ILD and lupus and scleroderma. Well, you're probably that combination sounds more like an ILD scleroderma thing. So treat the dominant manifestation when treating lupus and you'll be doing fine. I don't know if this is groundbreaking news, but the U.S. Preventative Task Force always comes up with new recommendations on what should be used. And it came out this week with an opinion against the routine use of vitamin D, with or without calcium, for the primary prevention of fractures or the primary prevention of falls in either men over 60 or postmenopausal women. So again, just because you're postmenopausal or over 60 doesn't mean that you get vitamin D or calcium because it's going to prevent fractures. In fact, the evidence for that is none. Nil. Zero. Zilch. Nada. So there may be other reasons why you might want to use vitamin D or calcium, but obviously those are going to go in high-risk individuals, right, who either by DEXA or their history might merit the use of vitamin D with or without calcium. But, a priori, just because of age, no, it has no beneficial effect on either fracture prevention or fall prevention. But we do know in this age group, that fragility fractures are in fact going up and they are associated with higher morbidity. So it's important to look for risk factors and then do the right thing. But age alone is not the risk factor. So let's talk about vasculitis. I think I've got two interesting things here about vasculitis I can talk about. One is this data about will being on steroids affect biopsy results for vasculitis. In this particular study, this was a study of from Tokyo, 126 patients who had suspected ANCA-associated, either small or medium-sized vessel ANCA-associated vasculitis, and the diagnostic test was a quadricep muscle biopsy. They of 126, 71 were positive and diagnosed with ANCA-associated vasculitis. The biopsy yield was the same if the patients were not on steroids or were on steroids. That the biopsy positivity rate was 59% for people off steroids and 53% for people on steroids, not significantly different. So being on steroids is not necessarily a hindrance to the utility of that test. It looks like, 50 to 60% of patients that could be a diagnostic test and should be considered. I think that's useful clinical information. The other vasculitis report was down here at the bottom about avacopan. I got this from one of my colleagues on LinkedIn, sent me this report. As you know, the C5a receptor antagonist, avacopan, is used in ANCA-associated vasculitis to treat GPA, MPA, hopefully to steroid spare. The main warning in the package insert, based on the clinical trials, is for liver side effects. In the clinical trials used for registration, abnormal LFTs were seen in 12 to 13% of individuals, and 4% discontinued the study drug avacopan because of liver problems. Well, there was a report this week in Japanese literature of 22 patients with ANCA-associated vasculitis and avacopan related hepatic injury. And that was seen in 9 out of the 22 cases they reported. It's kind of a high number. It's, 40% or something like that. But nonetheless, I think it's worth looking for this if you're going to use avacopan. Again, 9 patients had liver injury. It was severe with an elevated total bilirubin in only 4 of those 9. And 1 patient died from a rare syndrome called vanishing bile duct syndrome. Hard to know if that's associated with avacopan. I doubt it based on 1 case report. But nonetheless, the concern about hepatotoxicity with this agent should be on your mind if you're going to go that route. And I think we should be using the steroid-sparing drugs as much as possible. An interesting report from Italy on initial use of methotrexate in patients with chronic inflammatory arthritis, 242 patients, over half of them with RA, a third with PSA, 16% with undifferentiated arthritis. Overall survival of methotrexate was best in RA and PSA and roughly equal. It was about 60% at 2 years, 40% at 4 years, 20% at 96 months. And survival was not very good with undifferentiated arthritis, and that may relate to the diagnosis more so than the drug in those patients, right? Meaning that undifferentiated arthritis becomes something else or becomes nothing else, and so the drug is stopped or drugs are changed. But again, these methotrexate durability numbers are a little bit lower than what's been described in the past. 5-year numbers of 50 to 70%. This is 60% at 2 years, 40% at and I think that this may relate to 1, mixing populations, and 2, we have a lot of other drugs these days, and methotrexate isn't always our first drug. But in this study, it was the first drug. So I think it's encouraging and supportive data of what you expect out of methotrexate in your patients with inflammatory arthritis. A recent report showed the potential biomarker value of serum IL-40 levels in RA, showing it could distinguish RA from OA, SLE, and controls. That it did correlate not with disease activity, but with RA autoantibodies, coagulation factors, and was decreased in patients on TNF inhibitor treatment. IL-40 was, I think, described in 2017. It's a B-cell associated cytokine. It is involved in neutrophil function, extracellular traps, thought to be important in early RA, in the development of autoantibodies and progression maybe from preclinical disease to manifest disease. It seems in multiple studies to behave like a biomarker to some extent. Now, will it really be? It has to be tested that way for me to go that way. But again, its prevalence and how much it stands out seems to me like it may very well also be a future therapeutic target in clinical trials, but that hasn't happened as of yet. A study out there about axial SpA, an international study. It's called the International Map of Axial SpA. It's a survey of 5,500 plus patients, 3,200 in Europe, 770 in the USA. Mean age is 44 years. The important thing here is that this is a cross-sectional assessment of over 5,500 patients. The mean BASDAI score is 5.4. Active SpA is a BASDAI of 4 or greater. 75% had a BASDAI of greater than 4. The mean BASDAI was 5.4. We're not doing that good at managing SpA. What's the deal? the numbers were highest in South Africa. 87% had active disease, and 68% in Asia. I didn't see any exact reports for the UK, Australia, or the United States. But nonetheless, and not surprising, active disease in these patients was associated with functional limitations, spinal stiffness, and difficulty finding a job due to the spondylitis. Yes, we can do better. Last report is about tocilizumab efficacy in giant cell arteritis. As you know, it's approved based on the GIACTA study. I don't think we're using enough tocilizumab in managing GCA. And maybe it's going to take other drugs getting approved for GCA before we start jumping on that bandwagon and quickly moving on from steroids, because the data is we tend to overuse steroids here. But what they did in this particular study of 471 patients in Spain with GCA who were treated with tocilizumab is that they looked at their vascular phenotypes. What was the vasculature involved? And it turns out that the biggest group is, as you would expect, cranial giant cell arteritis, right? 46%. The least common was the extracranial GCA. That's only 17%, less than 1 in 5, and half being cranial. And the other 1/3, 37%, were mixed, cranial and extracranial. So we do know the extracranial patients tend to be younger, maybe by about 5 years, 66 versus 71%. And it had a longer delay to the diagnosis, maybe as long as 6 months longer. So the systemic manifestations were, and ischemic manifestations were more common with cranial giant cell arteritis. But the important point is that all these patients, how do they respond to tocilizumab? At 1 month, half the patients with cranial disease had responded and were in remission. It was 43% for extracranial and 47% for mixed. By 24 months, they were all doing very well. At 2 years, 79, 81, 89%. They're all doing great in remission. If you look at it, another measure of remission, EULAR remission, the numbers are about the same. Again, better responses seen with the cranial GCA at 1 month, 35%. The other ones were about 27, 28%. But at 24 months, 70+% were in EULAR remission. So these drugs work. And they work without regard for the vascular bed affected. And that's something to keep in mind when managing your patients with giant cell arteritis. I want to give you a preview. Go to RheumNow.live and look at the agenda. Click on the top and pull down the agenda and see our speakers. It's a great program. I mean, I know it's my program and Artie Kavanaugh's program, but where are you going to hear a lecture on how to manage morphia and linear scleroderma? Do you really know? Have you ever heard a great lecture on that? We've got a great lecture from Heidi Jacoby from UT Southwestern who's going to talk about that. We have a section on JAK inhibitors. John Giles talking about the end of the oral surveillance study. What do we now know 3 years later? Madeline Feldman's talking about when generics hit the JAKs. Tofacitinib is going to become generics in not too distant future. We're going to talk about TYK inhibitors from Joe Marola and where they fit. And Christina Charles Showman is going to talk about JAK inhibitors in dermatomyositis. Oh my goodness. The spondylitis pod, 2 hours on spondylitis, Desiree Vanderhyde, Catherine Bakewell, Jennifer Sal from California talking about hidradenitis suppurativa, and then a panel discussion. I don't think you're going to top this. We got a great lecture on EGPA, imaging and vasculitis, and management of PMR. All the best speakers in the business. RheumNow.live. Check out the agenda. I think you're going to like it. We'll see you in Dallas on February 8th and 9th. Have a great Christmas. We'll talk again in the new year. Ho, ho, ho.